Hello students, today's topic is pleural infusion. Let's start. Essay William Osler, to study the phenomena of disease without books is to sail to uncharted sea, while the studying books without patient is not good to see at all. Too many men sleeps earlier out of the habit to study reading, and yet that is essential. The pleura is supplied by its regional blood vessels. Hence, the cervical pleura is supplied by branches of the subclavicular artery. The costovertebral pleura by the intercostal arteries and diaphragmatic pleura from the vascular plexus from the surface of diaphragm. The venous drainage occurs into the corresponding veins with the drain into vena cava. The lymphatic drainage is onto the corresponding lymph nodules. For example, the intercostal lymphatic drain into the posterior lymphatic nodules and into the thoracic duct. The visceral pleura is supplied by the bronchial vessels and the lymphatic drain into the intercostal and peribronchial lymphatics. The parietal pleura is supplied by the regional nerves and contains the pain fibers. The costal and peripheral aspects of the diaphragmatic pleura are supplied by the corresponding intercostal nerves, whereas the diaphragmatic and mediastinal pleura is supplied by the phrenic nerves. Pleural effusion is defined as accumulation of fluid into pleural space that exceeds the physiological amount of 10-20 milliliters. That means 10-20 milliliters in the pleural space is normal. Pleural effusion develops either when the formation of pleural fluid is excessive or when fluid resorption is disturbed. Pleural effusion may represent a primary manifestation of many diseases, but most often they are observed as secondary manifestations or complications of other diseases. Pleural effusion is found in almost 10% of patients who have internal diseases, and main causes in 30–40% of this is cardiac failure. Among the non-cardiac effusions, parapneumonic effusions are most common at 36%, of which 75% are of bacterial and 25% of viral origin. Malignant pleural effusion follow in 18% of cases, half of which are caused by lung or breast cancer. Pleural effusion is secondary to primary embolism in 14% of cases, never forget about that, to liver cirrhosis in 5%, and to gastrointestinal diseases, mainly pancreatitis, in 2% of cases. It's too rare, but sometimes you will find out it at patients. Many other possible causes, such as collagen vascular diseases like rheumatoid arthritis and systemic lupus erythematosus, as well as several drugs, play an important role in differential diagnosis. Often pleural effusion are observed after abdominal surgery, liver transplantation, or coronary artery bypass surgery or pericardiectomy. Pleural effusion may be a result from a number of pathophysiological mechanisms, all of which disturb the physiological balance between the formation and removal of pleural fluid. Most effusions develop from both an increase in the entry rate of liquid into the pleural space and decrease in the maximal exit rate of liquid from the pleural space. Transudative effusion are caused either by increased hydrostatic pressure or by reduced plasma oncotic pressure because of protein deficiency. The pleura itself remains intact. Rarely, transudates may arise from the entry of liquids with low protein concentrations. In contrast, pathological changes in the pleura result in exudation caused by the diffuse increase of capillary permeability due or localized ruptures, or to disturbed absorption. Pleural effusion may present at all ages but is mainly found in adults. Malignant pleural effusion are observed predominantly in patients aged more than 60 years old. The most common clinical presentations are dyspnea and chest pain, and those of the individual underlying diseases. Physical examination reveals dullness on percussion, usually at the base of the thorax, and decreased breath sounds. Here you will see a diagnostic algorithm to pleural effusion. If you don't know etiology, you must do thoracentesis. After that, if it's positive and you find out malignant cells, bacteria, fungi, other specific parameters, that means you will treat that pleural infusion. Or you didn't find out anything, you do blind pleural biopsy and do histological test. And if you didn't find anything, you will do thoracoscopy, including biopsy. Investigative parameters of pleural infusion. You will see the parameters of the pleural infusion. Light criteria for exudates. If total protein more than 3, infusion concentration, uh, you will see also concentration ratio, sensitivity, accuracy. Markedly elevated amylase values are observed in acute pancreatitis and pancreatic pseudocysts, esophageal perforation, and occasionally in malignant effusion. Hemothorax is characterized by purely bloody effusion and hematocrit values that exceed those in peripheral blood by 50%. The helothorax increased triglycerides distinguish helos from the pseudohelos effusion. Also, nonspecific adenosine deaminase and T cells based interferon C released assays may allow support to diagnosis of tuberculosis as the cause of lymphocytic pleural infusion. Diagnostic testing of the infecting organisms that cause pleural infusion is indicated in parapneumonic infusion, empyemas with aerobic and anaerobic cultures, and in suspected tuberculosis, fungal, and parasitic effusions. Therapeutic aims in patients with pleural infusion is palliation of symptoms, pain or dyspnea, treatment of the underlying diseases, prevention of pleural fibrosis with reduction of pulmonary function, and prevention of recurrences. The therapeutic approach depends on the availability of the options for causal or only symptomatic treatments. Thank you for your attention.